with Dr. Kalisha Bonds-Johnson. So we have Dr. Kalisha Bonds-Johnson here. She has a BSN from University of Tennessee, an MSN from Vanderbilt, a PhD from Oregon Health Sciences University. She is a family psychiatric mental health nurse practitioner. She's a practice partner, so I love getting to work with her and gaining insights from the work that she does. And so I'm going to turn it over to you, Dr. Bonds-Johnson. Thanks so much for joining us today.
Thank you, Dr. Johnson. And I think I'm the other
I'm the
Dr.
other.
Johnson. No, I'm the other because I came after you. But anyway, I digress. Thank you all for joining. I will dive right into the presentation because 30 minutes goes really, really quick. I will say, as I'm bringing up my slides, this is not intended to be one of those, let me give you suggestions on medications. I think we can do that at some point, but I also recognize that we all sort of have our preferred psychotropic medications. I am not an expert in this field. I have some expertise in this field, but a lot of people do. And so I in no way want to feel like I am pushing my ideas on you, but just giving space for dialogue. And so this really is about what's the question behind the question. Oftentimes we get asked things by families, by staff working with families. And so I wanted to just present a couple cases of sometimes how I feel like this shows up. And then we can hopefully have some time to dialogue. Feel free to put things in the chat. I saw Dr. Johnson's poll everywhere, and I was not savvy enough to create anything like that before this. So yeah, feel free to put comments in the chat, questions in the chat, and hopefully we'll get to it. But without further ado, I do have to go through the actual and physically say, first, there is continuing education credit associated with these offerings. And then I do not have any disclosures to report, as you can see by the table. So again, sort of that idea of what is the question behind the question. I wish my IMC peeps would quit chatting because they are binging my computer, but I love them. So here's an example. Mom's not sleeping. Can I get a medication to help her sleep? And so this case is based off of a client that I have known for several years. We've changed the name. I've changed some of the demographics and information. But again, it's Monique. It's Mildred's daughter coming to you with that. Can I get some medication to help with sleep? So again, Miss Mildred Jefferson is a 75-year-old female who was diagnosed with moderate vascular dementia related to hypertension and diabetes. Epic team would love me for putting those reasons for the potential vascular dementia in there, but it was about 4 years ago when she received that diagnosis. Her daughter, Monique, is Mildred's oldest child and manages her healthcare needs. There is a son that pops in and out, but for the most part, it's Monique, Mildred, and you in most of the visits. Or me, I guess, in most of the visits. Mildred has episodes of psychosis. She does actively have visual and auditory hallucinations. Most of the time, it's Mildred's family. So her parents, she sometimes sees children. She sometimes sees other people. For the most part, these people are not distressing and disturbing to her at this point in the stage of the diagnosis. We do have her on some olanzapine that is helping with that because earlier on, some of these visual and auditory hallucinations and some paranoid delusions were resulting in Mildred becoming violent with Monique, physically, verbally aggressive. And so we did have to give her a little medication just to kind of calm the psychosis. So for the most part, we call them her visitors. They visit her pretty consistently, and it's usually really pleasant. So Mildred attends an adult day center about 3 days a week. She seems to really enjoy it. She's interacting with the other attendees. She's told me on numerous occasions she has multiple boyfriends, not just one. So she really is living her best life. Mildred can dress herself if Monique puts her clothes out. If she doesn't, sometimes it's the wrong seasonal wear or clothes are inside out or backwards. Mildred is still very verbal and expresses her thoughts and desires pretty easily. She's one of those clients that I do spend an hour with when they come to clinic with me. I have sort of flexibility between 30 minutes and hour appointments. And I've noticed with the visits where the person living with dementia is very chatty, as I like to call it, it's nice to have a little more time for her to express her concerns as well as Monique. And then for me to sort of guide both of them as we're discussing next steps. So as I mentioned, she's on a little bit of olanzapine, 5 milligrams at bedtime, a little bit of trazodone at bedtime, and some citalopram. So again, when I initially heard mom's not sleeping, I thought, maybe we should go up on the trazodone. But we want to know what's the question behind the question, right? And so I immediately, even though I have a plan A, a plan B, a plan C in my mind of what I'm thinking about medication wise, I also want to ask these questions. And so some of the first things I think is, why isn't Mildred sleeping? Hmm. This isn't necessarily a normal pattern for her. She does have a diagnosis of dementia, and we know individuals living with dementia often have a harder time sleeping. She is pretty active and does go to the adult day. Have they missed days this week? Is she maybe not as active as she needs to be, so she's not sleeping because of that? Like, these are the things I start thinking. And so then is this disease progression? And so, maybe sleep is off because there's been a level of cognitive impairment. And so really needing to sort of check in and see, has the disease progressed? Is she not just, not her best self because she's not sleeping, or is the sleep, the chicken or the egg, right? So if they're not sleeping, then they're not the best selves, or they're not their best selves because they're not sleeping. Is she saying anything? This is probably one of my favorite questions to ask, because oftentimes when families, whoever comes to us about a medication or about something the person living with dementia is doing, we often hear the behavior, like they were hit someone, they were wandering, they ran out the house, they aren't sleeping, they are anxious, they are irritable, they are whatever. But we very rarely, in my case, I can't speak for you all, maybe your clients are wonderful and give you all the information you need, but for me, really, a lot of times I don't get that needed information of like that antecedent, like what led up to the behavior that you are then bringing to me as the clinician. And so, is she saying anything is one of my favorites. In this case, when I said, is she saying anything? Monique said, yes, she has mentioned that her baby, and she sometimes sees children, isn't sleeping, and her baby hasn't slept for 3 days. And I said, well, how long has it been since Miss Mildred slept? Oh, about 3 days. And so any of us who are parents recognize that if we believe our child is not doing well, our child is not sleeping, our child is sick, we are up. We are working with them. We are trying to soothe them. We are trying to calm them. And in this instance, Miss Mildred wasn't sleeping because she believed her baby was awake and not doing well and hadn't been doing well for 3 days. And so then what are her behaviors? So again, she's not sleeping. She's talking to this child. She's trying to soothe the child. She's reaching out to her adult daughter and asking her to help with the child. So again, should I consider increasing one of her medications? Maybe, but the one I was thinking about increasing, which would have been the trazodone, is probably not the one I need to increase in this situation, because it's not sleep by itself that is the problem. It is that there is a fixed delusion, there is visual auditory hallucinations around hearing and seeing this child that is then resulting in Miss Mildred not being able to sleep. So is something interfering with her sleep? It is. And in her case, it was the psychosis that was interfering with sleep. And so we went up just a little bit. So went from 5 to 7.5 on the olanzapine, and then followed up in like a week. Nursing followed up to see how she was doing. And it turns out that once we were able to get that belief that the child wasn't sleeping, once that belief was fixed, no longer an issue, then Miss Mildred was able to sleep. So just kind of moving on to the next case. Larry is anxious all the time. Love it when someone's always doing something, right? Larry is anxious all the time. Can we get a PRN medication? Jessica, the wellness director at the assisted living facility where Larry lives, asked. So case study number 2, Mr. Larry Fitzpatrick is a 70-year-old male who was diagnosed with moderate Alzheimer's disease about 3 years ago. His wife, Kathy, who is a few years younger than him, manages his healthcare needs with the support of their son, James. Larry has been living in an assisted living facility for almost 6 months. So it's still pretty new. It was this decision. It's always a really hard decision. And I try to empathize with families because to make this decision is a tough one, but they decided to. So Kathy and James visit Larry often and like the facility staff. Kathy shares with you that the wellness director has noticed that Larry is anxious all the time when his family is not there. She recommends starting alprazolam, to help with the anxiety. He's on a little bit of citalopram, about 10 milligrams PO daily. That's something he was given when he received the diagnosis of Alzheimer's disease. This diagnosis is devastating to people. I tell all of my clients I would be more surprised if you weren't devastated in some kind of way, be it anxiety or depression or whatever that looks like for each individual when you are diagnosed with Alzheimer's disease. And so it's on a little bit of citalopram. We move back. So just to remind you, Larry is anxious all the time. Can we get a PRN medication? And so thank you, Jessica, for your suggestion. And her recommendation was alprazolam. So again, what am I initially thinking? First, I'm thinking we're probably not starting a PRN of a benzo for a number of reasons. We have the Beers criteria. When we think about the actual need of a PRN medication, one has to have the capacity to ask for that PRN medication. And with our people living with dementia, often they don't have that capacity. So then who is in control of that medication? At the IMC, we recently created a SMART phrase. I give all credit to Carrie Burdinsky for that, one of the amazing nurse practitioners I work with, because we get asked a lot about PRN medications, and it was like, we can come up with something on the fly, but wouldn't it be nice to just have this kind of 3-sentence reason for why we're less inclined to start a PRN medication? And that third sentence can be tweaked with whatever we think is more tailored to meet that need of whatever the reason is for the PRN. So again, back to the question behind the question, why is Larry anxious? And I don't know if y'all can see my whole screen or if...
Yeah, your screens are great. You
Wonderful.
keep going. You're doing good.
On my end, it's not great. So I'm glad y'all are getting the great version. Then the next one is this because of the recent transition? So I often tell families, and I'm sure you do too, that transitioning to a long-term care facility is a huge decision. It's a huge transition. I wish facilities gave people like a 3 to 6 month grace period, right? At least a 4-week grace period, at least a month. Oftentimes they don't even seem to give them a 2-week grace period, but recognizing that it's just going to take time to recognize where their new room is, where their new apartment is, how to get places, where to go, how often should the family visit, who are the people I contact when I need things. There's just so many different changes. And then when you add in a little bit of cognitive impairment, personality changes, depending on what, diagnosis someone has, any of those changes in thinking that we think about, it just really is difficult. And so I'm always trying to encourage people to just remember that they need grace. The next is, what is he saying during these anxious episodes? Again, what is he saying? What is he doing? What are the behaviors? 2 of my favorite questions. And so, again, in this situation, it was, he wasn't saying much. He just seemed to be wandering and pacing. And maybe he was saying, where is Kathy? Where is Kathy? I need to find Kathy. And so what are his behaviors? I sort of mentioned that. So he's wandering, he's pacing, he's looking for his wife because they have been married for, I didn't say, but let's say, 40 plus, 50 plus years. Does that math work out? That math does work out. So they've been married for 40, 50 years. He's used to seeing his wife every day. He is used to spending time with her. And so when you think about the question behind the question, again, should I consider adding alprazolam? I should not. I did not. Anyway, it's not even one of the benzodiazepines that I typically would consider in those I want to say caveat situations. There's a caveat to everything, right? There's always like an exception to rules, but even in the exception, alprazolam is not the medication I start with. We typically look at some lorazepam or something like that. But again, this does not seem like that situation. For me, if we're thinking about doing an as-needed medication or scheduling a benzodiazepine, it is more around a set behavior that happens pretty infrequently and not something that is happening all day long. If someone is anxious all day long, then giving them a benzodiazepine is really just giving them a band-aid. It is not solving the problem. And so the root cause then is that we need to treat that underlying anxiety. And in order to do that effectively, in my humble opinion, you need something more sustainable. So your SSRIs, your SNRIs, things like that. And then the next question, should the family visit more often or less often? And sometimes I tell people, we try it, right? So maybe it's Kathy visits more consistently. And for Larry, seeing her more consistently, if that can work for Kathy and doesn't cause her too much burden, maybe his behaviors decrease and he isn't pacing and wandering and looking for Kathy because he just saw Kathy. Or maybe it's instead of her staying long periods of time, she comes at multiple times of the day. Maybe she tries to come at morning, in the afternoon, and then before bed. Instead of staying, 4 or 5 hours in the morning and then having to leave and not come back. Or maybe it's that she's visiting too much and him seeing her consistently is actually making him more anxious. So I don't want it to be that we're only looking at medications. There are often some wonderful strategies that do not involve medications that we can think about. But let's say we've tried, Kathy's visited more consistently. He's still anxious. Kathy's pulled back and visited less often and he's still anxious. And so maybe after we've tried these things, it is that we consider going up on the citalopram. So maybe we go from 10 to 20 milligrams to see if that has more of a staying power and helps to kind of calm him and helps with that anxiety. I don't know if there are any questions. I don't have much else. I just wanted to kind of give us a couple of teasers and things to think about. And then if there were any particular questions, we could.
You do have a question from Dr. Birju Patel. Hey, Birju, thanks for joining again. I'll read it out to you. Case one, you mentioned, in case folks are on the phone in the car, here's what it says. Case one, you mentioned increase in olanzapine over trazodone due to delusions and hallucinations interfering with sleep. It is not safer to increase the trazodone to achieve better sleep, understanding that this is addressing sleep instead of delusions. I'm always concerned about increasing doses of an antipsychotic.
Yes, we all are, right? I think it's a great question. It's always that tension in the room anytime I mention an antipsychotic. I'm honestly not opposed to someone increasing the trazodone. Maybe you increase the trazodone. Maybe in that case it was at 25, maybe you go to 50, maybe you go to 75, maybe even push it to 100. But what I have seen over the course of my career is that if a behavior is led by psychosis, typically it is the antipsychotics that tend to have better improvements in those behaviors. But I don't think assuming that, the increasing olanzapine is the only way to go, because it's not. If you're more comfortable with increasing the trazodone, try it. Go from 25 to 50 if they sleep. Maybe you follow up in a couple days because trazodone is not one of those meds. It takes forever to work. We're actually benefiting from its side effect. And so, you give it to Mildred for a couple of nights. Does she sleep? Maybe you go up again. Does she sleep? And maybe it does get to a point where she's actually sleeping in spite of the psychosis associated with the child not sleeping. Again, I think it's just kind of provider preference.
Let's stick with that question just for a second and maybe go one level deeper. And then I do see Antonio Rios's question, and we'll get to that one in just a second. So the other thought that I have in these situations is, so I have a 2-year-old niece, and I'm getting pictures from my sister all about my nieces carrying this baby doll with her everywhere. Yes. The baby doll is at lunch. The baby doll is on the tricycle. The baby doll is going to swim lessons. The baby doll is everywhere. And so what do you think about, looking
the baby doll?
Yes.
I like the baby doll idea. I always tell people though, buy it on Amazon or somewhere where it's easy to return because not all older adults like baby dolls. Like some people like really get into it and they do feel like it's their baby and you can see them doting on that baby doll and it really feels like they're invested. And others, I think, see it as a baby doll. And so there isn't that connection that you see. For her, we had considered that because this child does periodically come up, and I can't remember if her daughter was hesitant to try it or we tried it and it wasn't successful. But I do remember bringing it up. Another one we used a lot, not necessarily for sleep, but maybe for anxiety and somebody that's kind of fidgety, is the desire to, if they were a homemaker, folding clothes. I remember working in long-term care and I would give this lady a basket of laundry because she was just kind of busy. And if you could give her something to do with her hands, she responded well. And so I'd go behind the nurse's station and I'd mess them up, even though she just folded them. I'd take them back out. And she's like, "You have so much laundry." And I was like, "I do, but I'm so appreciative of you for helping me." The other one is we had a man who I think he was a carpenter or something, but we had this box that had different locks and keys and different little gadgets and gadgets. And he would spend hours trying to figure out how to open the box and turn the keys and different things like that. So, another question I always like to ask, and I didn't put it in here, is what that person did for a living. What brought that person joy? Because sometimes we can get really, really creative, especially with the non-farm options when we know like sort of what made them tick and how do we sort of create something dementia friendly that aligns with that.
Intervene and follow up. We had a veteran in our long-term care facility who was a mechanic, and we gave him a toolbox. And he did take another resident's wheelchair apart. So you always want to make sure and monitor kind of what's going on.
There is that.
I know. Let's go on to the other question from Antonio Rios. Thanks for attending and thanks for your question. Other than visitation, is there anything else in case two that could help, such as phone calls from the wife and son, etc.?
No, I think that's a good idea too. It also depends on kind of the level of Larry, given that he was recently moved to the facility. Sometimes phone calls are really, really helpful. FaceTime, just being able to see that person. In this case, I tell a lot of my spousal caregiving families that you're kind of like their security blanket, right? So sometimes just seeing you, just hearing your voice lets that person know everything is okay. Sometimes we've talked about recording messages, and then that way staff can play it, like, "You're okay, Larry, everything is fine. I'll be there later." Or if you can do a quick phone call. Again, it really is, I think that's a great idea. It really is kind of catering and tailoring it to what seems to work, but really being able to monitor, are the behaviors more intense or less intense? Because for some people, out of sight, out of mind is great. Not the same at all. I know Dr. Johnson mentioned his niece. I have a 20-month-old son, and so we are in the process of we have weaned his pacifier. So daycare completely got rid of it, of course, right? Because they're daycare and they're wonderful. So my son doesn't take a pacifier at all at daycare. But at home, he was taking it when we would drive in the car, at naps, and then at bedtime. But we got rid of the driving. Now it was before this week, it was just naps and bedtime. But I noticed for him, out of sight, out of mind. So he actually wants his pacifier more when he can physically see it in his crib. So we were like, let's just take it away and see how he does. It's been about a week and it's going well. So sometimes, again, for some people, it's more visitation, it's more contact. For other people, sometimes it's less contact. And this reminds me of another case we had. Again, I have a lot of long-term care experience. And so we had this one family member where his wife had passed away. And he was looking for his wife. So he's going up and down. He was probably moderate, late stage dementia. And he would ask for his wife. And a couple of times at the nurse's station, the nurses would say, "She passed away." And he would cry and sob like he had just heard it for the first time. And so we finally asked the family, when his wife wasn't with him, where would she be? She'd be getting her hair done. She'd be at bridge. And so we had this list of things we could do, similar to Larry, maybe it's, I'm looking for Kathy, I'm looking for Kathy. Well, she went to go get her hair done. She went grocery shopping. And so sometimes that's another way to be creative and understand what are the normal patterns in their family dynamics in their relationship that we can use. Again, when we're a little hesitant, maybe we don't want to make medication changes. Maybe Larry's been really stable on that citalopram, and we think it's just related to this transition. And so we're wanting to see, can we put some non-farm strategies in place?
There are so many things that I love about this talk, and I appreciate your giving this talk today. And so one of the things that just really fits for me, knowing you, is the inquisitiveness that you have and the caring that you have. The other thing that I'll add is that there's kind of what Candace Kemp would call meaningful engagement, meaning that you're trying to come up with something that's purposeful, soothing, helpful, and kind of meeting people where they are. This, reminding someone that his wife died just is that fresh wound, and maybe she's at the hairdresser is a lie, but it's certainly a less painful lie. And sometimes you could even just improv off of that and say, oftentimes she's at the hairdresser, and what do you remember about Kathy, and on and on and on.
Yeah.
I wanted, yeah, go ahead.
No, I was gonna say, I actually just had this conversation yesterday, and I'm like, what I'm comfortable saying, may not be comfortable saying. So you may have to, like you said, improv, practice it out when certain questions, because we start knowing our clients, we start knowing their families. There are certain questions that just kind of consistently come up. What would you say in that response? I think the other thing that is sometimes forgiving is that with a diagnosis like dementia, you get another chance at it, right? So if you totally botch it, you totally say the wrong thing, guess what? A few hours later, the next day, you got another chance to figure out what that winning combination is for the client.
That Ted Lasso goldfish example.
Exactly.
Right? Be a goldfish. Hey, Dr. Anna put something nice in the chat. I really appreciate how you go deeper into the why. Sometimes we don't take time to get to that. So key, and thank you. So Dr. Bonds-Johnson, if you could just go ahead and go to the feedback slide,
Yes.
Just reminding people how they get credit and can talk about the great things that they learned
Perfect.
in this call today. That's awesome.
I will add, sometimes I'm not the one that does the deep dive into the questions. We have amazing nurses, Elizabeth and Elizabeth, although one goes by Liz now because they're both named Elizabeth. They are phenomenal at taking sort of these questions, like what are they saying, what are they doing, hearing me ask the same questions over and over again. And so when the families reach out, when the wellness director reaches out, they then reach out on my behalf to sort of dig a little deeper, which then helps me plan the treatment plan options. So again, I cannot take all credit. It is a team approach. And so as providers, we are tapped. We can't click another box. We can't do another survey, but sometimes having those really great support staff, that care team that supports us, if you can have a couple of quick key questions in certain situations you'd like for them to ask, sometimes that's another way to be able to get that information.
We've asked our facilities and we've asked our family caregivers to be problem solvers. And so, we have to support them in that problem solving, but then when they get to a point where we need to back it out and ask those questions behind the questions, you've given us a great approach to do so. So thanks so much, everybody. Emma, wanted to turn it over to you to see if you had any additional information to share with us today. And I think we're good for today. For those of you who are applying for credit via credit by text, one more time with today's session code, please.
Pardon me, I didn't hear you earlier. I wasn't able to get off mute. No, nothing else.
What's today's session code? It is 18061. So if you've done 18061, if you've done text for CME credit, you could do that. And otherwise, there's that survey that you've had a chance to answer, and you can get CME through that as well. Hey, thanks, everybody. Really appreciate you joining. Dr. Bonds-Johnson, thanks so much. It was awesome.
Thank you. This is great.
Thanks for having me. It was great.
All right. Take care.